Bismillah ar-Rahim. I would like to thank again the organizing committee and all people here for the invitation, and thank you all for staying late during the day. I will talk to you about time range. This is my disclosure. This is a case from my clinic. This is not a story. Scientific stories are coming, so stay tuned. This is a case of 39-year-old male, type 2 diabetes for 12 years. He is on insulin, glargine, aspart, plus tablets, metformin, sitagliptin, complaining of hypoglycemia episodes at different times of the day, but his A1C is 7%. His A1C is excellent. Okay, so I will need your help by the end of my talk to help our patient. Now, this is the agenda of my talk. Okay, this is what we call it the triangle of diabetes care in the era of technology. It is not just to improve the control of the sugar levels indicated by A1C and time and range now, but also we need to limit variability and we need to avoid hypoglycemia to reach better outcomes. And I mentioned in previous triangle two terms, time range and variability. What is time range? Time range is the percentage of time that the person with diabetes spends within the target glucose level, which is generally between 70 to 180. And the metric comes from CGM. What is variability? Variability is the spread of glucose values. It can go like that, like roller coaster, as you can see in some patients with type 1 diabetes especially. Time range and CGM is not a rocket science. Okay, it is part of our work. It is in guidelines for primary care physicians. Okay, so it is not a rocket science. We should know about it and we should use it in our practice with our diabetes patients. This is the AGB profile I mentioned in the morning. We can call it the ECG of diabetes, and we'll go in details by the end of my talk about the AGB. This, if we want to compare the finger sticks, this patient acceptable, but when you put CGM, you will miss highs and lows. You can see all of this. So CGM treats something, I call it doctor unawareness. It treats our unawareness of the glycemic levels of the patient, so we can help our patients in a better way. And I think you see this during the day-to-day about different A1C, but different profiles. All of these are excellent A1Cs, but the profiles are not the same, not are all good. This one is fine. How do I know it is fine? Time range is excellent, variability is good, no hypos. This one, little bit, time range is okay, but a lot of variability, increase the hypos. This one is not really good. You should do something. You cannot leave this patient to leave your clinic without an action. A lot of hypos, time range not good, and high variability. So, what are the characteristics of a good glycemic metric? Metric, it means system or standard of measurement. And to have a good glycemic metric, we need to have a criteria for that. We can call it MURAR. What is MURAR? What is this metric should be measurable, it should be understood, should be relevant to the outcomes of diabetes, should be actionable, I can modify it and follow it, and should be reliable. So what the metric we have nowadays, the gold standard is HbA1c. Is it MURAR or not? Let's see. Our metric, the A1C, it predicts complications. It is good. It predicts complications, of course, as you can see, with higher A1C, more complications. Easy to understood and to explain to our patients in the clinic. Although some patients, when you tell him you need to do A1C, he'll tell you, I'm not fasting. It has no relation. It is like this number. I'm just eating my food. No, it is just as average last 3 months. So still, not everyone understand that. It has clear targets, of course, and we're familiar with it. We can use it for management and for diagnosis, of course. But it is not perfect. Why? It has some factors that affect its accuracy. It has still delay in management. We need to wait 3 months to see a change. This adds to therapeutic inertia. For example, in surgeries, we get referrals from surgeons. They want to control diabetes of the patient. Then they tell the patient, wait 3 months. I want to do surgery now, wait 3 months. How come? Okay, another also, doesn't address the effect of daily life activities. If I do exercise now, if I eat great lunch here now, Okay, A1C will not reflect that. A1C doesn't measure the hypoglycemia or variability. This, I think all of us know about this, a lot of factors that can affect A1C accuracy. So in conclusion, for A1C, is it MURAR? It is measurable, understood, relevant, actionable, so it is MURAR, but is it reliable? Also, as I said, at least the familiarity. Should we abandon the A1C based on that? No, at least for the now. It is familiar, we are familiar with it, predictive complications. However, it needs a younger generation metric to help for the shortcomings of A1C. And here, a scientific story will start, the story of time and range. CGM, like invented before, for many years, end of like 1990s, okay, and we are getting data. So this data like a tsunami of data. Now we have CGM measuring every minute, which is 1,440 readings per 1 day. How we can get benefit of this data in a quick 1 minute in the clinic. So the story after this, all of this data, the international consensus on use of CGM and another publication, the need for regulatory change to incorporate beyond the A1C glycemic metrics, came with these suggestions and these metrics from CGM. And you can see time range between 70 and 80 proposed to be used as a metric for control, among other metrics. Also, in the consensus in 2017, they mentioned about a secondary metric which can be between 70 to 140. And I will come to it. This is another story. So by CGM, we go beyond the A1C, we get time and range, we get hypoglycemia and hyperglycemia, frequency, duration, severity, and we get also knowledge about variability and the stability of the glycemic levels. Here the story will start. So we have A1C, and we have diabetes complications, and we have time and range. It is well known, the A1C and the complications relation, based on the big two trials, VCT and Equipedes. Okay? If you want to use a time and range as a metric, okay, is it related to A1C? Is it related to complications? So you can convince me to use it. This is from DCT, relation between A1C and the complications. So I need to establish a correlation with A1C and establish another correlation with complications. That's why I will be convinced to use it as a metric. Let's start with the correlation with A1C, between time range and A1C. 3 big studies with type 1 diabetes patients, 451 patients. They get their data from Diamond study, replace PG and the high body. And they found the correlation between the A1C and time range on those patients. The A1C levels and time range correspond to H levels. And this is from why we are targeting a time range around 70%, because it correlates with our general target in A1C of 7%. Another study by Vigreski and McMahon, they reviewed 18 publications from both type 1 and type 2 diabetes, and again they found good correlation between time and range and HbA1c. Recently, the SWITCH-IMPROVE study, which compared the Glodic and the Glargine U100 in a crossover battle, they get all the data, they use CGM in this data, and they establish also, they found a good correlation between HbA1c and time range. Because here in this study, they check at baseline, in the end of first part of the study, end of last part of the study. And they found that all the stages, there was a good correlation. Also the change, not just the time range and A1C, the change in time range and HbA1c, it was correlated also. So I think we have completed this part. There is a correlation. So let's see the story of the second part. Is time range correlated to complications? If you want to do this, do you want again to do another DCCT or Equipedes? I think no one have money to do it again and wait this long time to establish it. So they did something smart, what they have done by Beck Roy, what he did. They went back to the data of DCCT. It is all by finger sticks, okay? They got like 1,440 participants data. They were doing like 7-point finger sticks per the day, and they make these data like the data from CGM. Data, these readings, those within the range, those readings above the range, and those below the range. And what they found? They found, so this time range here from the data of finger sticks in these CT patients. Okay, with the better time in range, less retinopathy. With the better time in range, less microalbuminuria. Also, other studies which are done with CGM, this time, also there is a good correlation between severity of retinopathy and time in range. Also, between microalbuminuria and time in range. The better time in range, the less retinopathy and less microalbuminuria. Also, carotid intimal thickness, the better time in range, the less the thickness. Cardiac autonomic neuropathy, the better time in range, the less cardiac autonomic neuropathy. So from all of this, it has relation to complications. Also, CGM used in pregnancy. Okay, the landmark trial concept trial compared CGM versus the finger sticks in pregnant ladies. And with CGM group, they got all the metrics of CGM were better with them. And in these studies, by the way, if you have arm with CGM and arm with finger sticks, how you can compare both? They put for them blinded CGM at certain time points in the study to have data from both CGM. Here it is the personal CGM in the intervention group, and from the blinded CGM in the finger sticks group, and they compare both to them. A1C is better in CGM group. Pregnancy outcomes better in CGM group. So I think we established now the correlation between time and range somewhere with the complications. And by this, we can, is it time range now can be a metric? Is it mirror? It is measurable, of course. It is well understood. You can tell the patient in the clinic simply, your sugar in the last 1 week, in the last 2 weeks, was 70%, 50%, 80% within the target range. I think this is understandable. Is it relevant? Of course, actionable. It is a number, and reliable. Also, it helps against therapeutic inertia. You can do escalation just after 1 week or so, or after 2 weeks as a recommendation. Bring the patient again, check the report, and you can advise. Also, a patient can see the effect of his daily activities on his sugar using it, plus other metrics about hypoglycemia, hyperglycemia, and the variability. And by this point, the story of using time range as a metric in clinical practice was in Berlin in the HTTD conference 2019, where the consensus on time and range put their recommendations, and you can use time and range now. And these are what they advised: time and range between 70 to 180, level 1 and level 2 above, level 1 and level 2 below, and variability. And what are the targets for that? The targets, as you can see, for usual cases, type 1, type 2 diabetes, you need 70%, more than 70% green in range, less than 25 above the range, less than 4 below the range. If you have fragile patient, like you change your target in A1C for them, also you change your number target in CGM. So still between 70 to 180, but you need just above 50%, less than 1% below this range, less than 50% above this range, but take care, don't go more than 250 by more than 10%, because this affects the quality of life, of course. In pregnancy, based on concept trial and data from Swedish registry, they put the pregnancy specific time range between 63 to 140 to be more than 70%. So same numbers, more than 70, less than 4 below it, less than 25 above it, but the target is different, 63 to 140 in pregnancy. For type 2 and GDM, we don't have RCTs. So you cannot see a specific number recommended, but you can get the test of an expert opinion that in type 2 diabetes, take care. Patient was type 2 or GDM. If they opt to use CGM during a pregnancy, you need 85 almost to 90% with a range, not 70%. 85 or 90% with a range. And each increment in time range by 5%, it has clinical significance. So appraise your patient. If patient, for example, bad control, now still bad, but 5% more. This is clinically significant. Appeals your patient, motivate the patient to get better and better. Another milestone for time in range, and again the consensus in 2023, they put it as an outcome in clinical trials. So you can build a clinical trial and put you can make not A1C as an outcome, makes time in range as the outcome of this clinical trial. And this recommendation endorsed by all these bodies. I think if any one of us treating diabetes, you will follow at least any one of these. No other authorities you follow outside these guidelines. Okay, now another story, step further, okay? We want to learn about time and range. Okay, now please learn about time and range because we may move to another metric, which is time and tight range. Okay? So what is time and tight range? This story is evolving now. Time and tight range describes the time individual spends in normoglycemia, between 70 to 140. Okay, very motivational target. Why we need it? Glucose control in healthy children and adults, if you look at this study, when they look at the glucose control in healthy children and adults, those patients in general spend 96% of their time within this range. So people, normal people with normal glycemia, they spend 96% of their time within this range, between 70 to 140. So why not to hit this target? I know that there is variability in insulin requirements, as I mentioned in the morning, the limitation to us, and we are afraid of hypoglycemia. But if you have something now, as I explained in the morning about technology, and as Dr. Ahmed explained in the morning about the new incretin therapies, these two tools in our hands now for both type 1 and type 2 helps us to push more for better control. And you now find the studies about this technology and the incretins, they report the time and tight range now in their studies because they can achieve a lot within this tight range. When we say to our patients, I want your A1C less than 7, we are limited. Unfortunately, still the mortality is high. Of course, he's controlled. I tell the patient, you are great, you are controlled, A1C less than 6% or less, but actually mortality is still high. But we cannot do more. These are our tools. But currently we have stronger tools to push more. Again, is it correlated to A1C? It is correlated to A1C. Is it correlated to time in range? Yes, it is correlated to time in range. Good correlation, 0.94. Is it available in guidelines? This is from pediatrics, the ISPAD guidelines. What they said, when using CGM, reasonable treatment target 50% time tight range, you can hit for it, and you want 50% in this tight range. In adults, also it can be used as a secondary outcome in clinical trials, time and tight range. Okay, so learn time and range because now we may move to time and tight range. Okay, so I spoke about the ambulatory glucose profile, where you get a tsunami of data from CGM, a lot of numbers. You want to make it easy to the physician in the clinic to help the patient in a few minutes. So all of this reported in one page, we call it the AGB, ambulatory glucose profile. What are the components of this profile? First, it has the targets and the statistics part. It tells us the timing of this report, time sensor active. We need at least 70% data available. The average glucose level, the glucose management indicator is a new name for the estimated A1C, the variability, we need it less than 36%. It has the bar for time in ranges, time in range in the green, time above range in yellow, and level 1 and level 2, level also 1 and 2 in hypoglycemia range. The third component is the profile, which tell us in this period of time, for example, 2 weeks, where is the hyper or hypoglycemia is happening for this patient, and then a daily profile, if you want to specific days. So I know most of us, especially primary care physicians, they are busy in the clinic. Okay, they don't have time. So if you want to interpret this report quickly in three easy steps, and it is scientific, it's not just make it easy, okay? We can just do 3 steps. First one is review the time in range bar to see what is the problem, this first question. Then second, identify where is the problem from the profile, and then third step is to treat, act with the patient, of course, as a shared decision. So first, quickly, we'll look at the bar of time ranges, look to the green and to the red. We need more green and less red. From here, you will learn, is it a problem with hypo or hyper or both? Then quickly look to the profile. You need it, we call it FNIR, flat, narrow, and in range. Otherwise, you see where is the problem. And based on that, you will take an action. It will end within this table at the end. So you will look at time in range. If it is good, time below range is fine, no changes, excellent. If time range above 70, but time below range is a problem, it is a problem of hypoglycemia. So look to the profile to see when is the hypoglycemia and treat it. If time range is not good, less than 70, but time below range is good, so it is a problem of hyperglycemia. So look to the profile to see when is the hyperglycemia and treat it. Is the problem with both, it means there is high variability and hypoglycemia. Work on the hypoglycemia, and here you need educator to teach the patient, review the behavior of the patient to avoid this high variability in glucose levels. Factors that affect variability related to behavior of the patient, like taking insulin after the meal, for example, or immediately before the meal, missing doses, exercise. We don't tell the patient don't do exercise, but we should educate the patient how to do it in the proper way. Now back to our case, the 39-year-old male with type 2 diabetes for 12 years. He's on insulin, glargine and aspartame plus tablets, hypoglycemia during different months of the day with A1C of 7. We bought CGM for him, and here is the profile. Very important point, we don't treat reports, okay? We treat patients, so we need to take history. Just learn from the patient about his lifestyle, his bedtime, his breakfast timing, lunch and dinner, if you do any other exercise or no. So this is the timing of his meals and during his bedtime, and you can see what's happening for him. He has good control, but if you look to the 2 steps here, what you can see, he has problem with hypoglycemia. Okay, his time range is fine, but he has problem with hypoglycemia. So the problem is hypoglycemia. When is it? It is at different points of the day, during night, and before meals. Okay, so what action? Now, what I'm projecting from here, it is, I'm not telling anyone how to treat diabetes, okay? You have the skill to treat diabetes, but it's a skill how to get the information and then apply your skill to treat diabetes, okay? So to get the information, this is the way. Look to the part, what is the problem, then where is the problem, then just treat. So this patient, we may propose to decrease, for example, the dose of long-acting insulin for him. This will help these hypoglycemias during night and before meals. So the take-home message, time range as measured by CGM provides the information beyond A1C about variability, hypoglycemia, and hyperglycemia. A1C correlates with diabetes complications. However, it has shortcomings that are complemented by time range. Time range correlates with HbA1c and is correlated with diabetes complications. Time in range and CGM use has been recommended as a standard approach in clinical diabetes care. Time in range can be used as an outcome measure in clinical trials. Now, the time in tight range describes the time individual spends within the normal glycemic range between 70 to 140, and it is correlated with both A1C and time in range. Time in tight range, if you use it, the target is 50%, okay, within this tight range. And when you have the AGB, it is easy 3 steps. What is the problem from the time range bar? Where is the problem from the profile? Then act with your patient. I know this maybe you need lab review, okay, to help with your patient with that regard. But sometimes you have the patient, you don't have lab review account, like primary care physician in his clinic without LibreView account. Patient coming to you, he's saying, I'm using this sensor. How you can help him? It is very easy. Same steps. Tell the patient, please open your application. He will open the application for you. Then you yourself, you need to click 2 clicks. 1 click on the time and ranges. You will open it and you will get this bar. Okay? Then another click on the daily patterns, then you will get the profile. Then you can treat the patient if you don't have LibreView. Okay? Thank you.